Otherwise, we'll forget. Good morning, good afternoon, everyone. Just going to give it a couple of minutes or so for people to join, but welcome to those who are already with us.
Crash, you have a gray icon on your screen. I don't know what is it, but it's
Is that gone?
it's okay now. It's okay. There was a
Okay.
gray icon on your screen.
Oh, okay. I think I was just trying to look at the participants. That's fine. Okay. Um, well, I think we might get started. Looks like we've got quite a few people coming on board. So hopefully people will filter in as we get going. But just wanted to say good morning and good afternoon again to everyone. I'm really glad to see so many of you joining us. Can see a few familiar names there on the participant list, so welcome to those. For those of you who don't know me, I'm Prashanthi Atwood. I'm the lead for the UK injury team at the George Institute for Global Health in the UK, and I'll be your moderator for today's session. Um, this series is really a joint initiative between WHO and WHO Afro and us here at TGI. We're in the second session of a series of five. Today's session is all about prevention pathways from home hazards to safe environments. Last month, we built the sort of the epidemiological picture, and today we get into what we actually are able to do about it. Um, so just to kind of orientate everybody, we have sort of five sessions over the course of about 5 months, building from burden through to prevention, emergency response, longer term care and policy, with sort of everything really feeding towards Safety 2026, the big World Injury Conference in Cape Town in September. And uh, this is a sort of a nice visual of kind of where we're at with this series to try and sort of raise awareness of burn injuries and things that we can sort of learn from and do from and learn from each other during these kind of five sessions. So we had last one in March, we're here in April, and we'll go all the way through to September. So I would urge many of you have registered for our whole series. So we'll welcome you to all of those. Just a quick housekeeping. Please do stay on mute unless you're speaking. Please use the Q&A box for questions throughout. We will have a panel session at the end, and one of our team is monitoring that Q&A session so we can bring those in to the panel at the end. Use the chat for introductions or for anything technical that you need help with. We are recording today's session and it will be made available. We'll share everything with all of our registered participants. So please just enjoy the presentations that we have today and the panel discussions. Before I bring in our speakers for today, I just want to do a really quick recap of session one, particularly for those of you who may not have been able to join us for that, because it really does help set everything up that we're going to be talking about today. So last month, we were joined by Dr. Dennis Mazingi, Prof. Barclay Stewart, and Dr. Caroline Zasik, who joined under the moderation of Binta from WHO. And they walked us through the kind of the burden data. The numbers that stayed with me from that session were really about sort of how we had like 10 million incident cases of burns a year globally, with over 10 million disability life years lost as a result. And Dennis made the point that burns are really very much a story of survivors, right? People living for years, sometimes decades, with the consequences, the disability, the stigma, the lost schooling, the lost income. So the burden is actually much bigger than the mortality figures necessarily suggest. And we learned that Africa carries a disproportionate share of that, and children are at the center of it. Under fives, under 19s all have the highest incidence of burn injuries. But the thing that really landed for me was the sort of the deprivation analysis, that lens. Dennis showed that people in multidisciplinary or multidimensional, poverty, around 18% of the global population, account for about 60% of burn deaths. And it's not just poverty in general that drives this, it's the specific deprivation, it's the unsafe housing, the household energy poverty, the overcrowding, the limited water access. So, two countries at exactly the same level of GDP may have very different burn risks depending on how those deprivations are distributed. Barclay then added the registry picture. Most burns in sub-Saharan Africa are cooking related. Most victims are under five. Scalds dominate in the very youngest. And he and Dennis both made the same point that we focused too much on acute care and not enough on prevention. Improving treatment alone won't shift the burden. So we have to be able to reduce the number of children who are getting burnt in the first place. And that is what today is all about. So without further ado, I want to introduce you to today's speakers. We have Dr. Charles Simagabu, who is a researcher and lecturer in the Department of Disease Control and Environmental Health at Makerere University School of Public Health. I've worked with Charles for many years now, so I'm really pleased to have him on board. Charles works on unintentional childhood injuries, understanding their burden, designing and implementing prevention strategies in low resource settings. And his current work focuses on identifying and reducing burn injuries in homes and on first aid and early response in very resource limited communities. And we've also got the privilege of being joined today by Kenneth Nandala, who is joining us from Jinja in Uganda today. Kenneth himself is a burn survivor and works as a community house inspector in Jinja. And I first met Kenneth last year when we were doing some community participation work in Jinja. So I'm really pleased that Kenneth's going to be able to join us. And Charles will introduce him more after his presentation. And Kenneth will also be as part of our panel. So welcome, Kenneth. Then we have Lawrence John Okoth, who is Director of Design, Innovation and Communications at Design Without Borders Africa, based in Kampala. Again, Lawrence and I've worked for many years. He's got over a decade of experience applying human-centered design methods across products, services, systems, and architecture in the humanitarian and the developmental sectors. So he's going to show us what that process looks like in practice today, including some audience participation. So please do have your phones ready because I know that he's got a Mentimeter ready for us to make it a little bit more interactive. And then we have Zaitun Rabbani, who's our Executive Director at ChildSafe South Africa. She's got over 30 years of experience spanning social work, community development, and child injury prevention. She was instrumental in embedding child harm prevention in South Africa's national strategy to accelerate action for children, which was approved by the presidency last year in 2025. So absolutely brilliant. So just to say, they're going to lead off with some of the presentations that you'll hear. So sit back and listen. Please, again, do pop in Q&As throughout, and then we'll have time at the end for a panel discussion. So do shoot questions at them. Charles, I'm going to hand over to you. So I'll stop sharing, and if you'd like to share your screen, and I will go on mute.
Yeah, well, thank you very much, Prash, for the introduction, and I hope you can hear me correct.
Yes,
Just
we can,
confirm.
Charles. Yep, that's great. Thank you.
Yes. So, as introduced, I'm Charles, and I'm based at the UK University School of Public Health, where I'm doing some work on, bans, and worked with the George Institute for quite some time. Prash, Maggie, Dennis, and a few others. So, I'll speak briefly about the household level risk factors for childhood bans that we have probably encountered in some of the work that we've done here in Uganda. Um, Certainly, this is, I think, a very timely webinar series, and as we all know, that bans are a major public health challenge in Africa, especially in informal settlements where I majorly work. And it is very evident from the data that the bans problem is more pronounced in children under 5. So as you can see in the two graphs, I shared two case studies of studies done in Uganda and Ghana, and you see that it's very evident that bans are more prevalent in children, especially those under 5. And certainly there are some underlying causes for the ban risks that we see in the slum communities. These communities are heavily overcrowded, and that increases the number of risks that can result into bans. The type of energies used there, coupled with how hot equipment and liquids are handled. Later on, speak about the supervision that is done for the children, under 5 by the caretakers and parents. Then think about how curious children can be, with them trying to touch everything and trying to mimic everything that they see. But also we see that there's a lot of acclimatization to ban risks within homes, to an extent that a risk is there, but a parent or the caretaker doesn't actually view it as a risk and takes it as a normal situation till when it has harmed the child. And so those are some of the things that are underlying some of the risks that I'll discuss in a minute. But specifically, why focus on household? From our work, we see that 95% of the bans among children actually occur in home environments, in areas like kitchens, dining areas, bathrooms, from household electrical appliances and other outdoor engagements, like people cooking in open spaces, and probably not taking good care of chemicals that could actually burn children. And from this pie chart, you see that we probably see more bans happening in open cooking areas compared to people that actually had a kitchen in a separate house where they cook from. So indoors, probably cooking from indoors has many bans happening there. Cooking from open outdoors has more bans happening there, with very few happening from outdoors. And this figure was drawn from numbers study done in Uganda by our colleague. What are the major household risks for bans that we see in our work? Of course, a lot of them stemming from the type of energy used, location of the cooking stall or apparatus, spillage of hot liquids, contact with hot surfaces, open fireplaces, household appliances, and access to flammable equipment and substances. And now, I'll share some of, the community voices and the data that we see from our work on specific risks. So type of energy used for cooking and lighting clearly is one of the burns risks in our settings. Here we hear from a focus group where a mother says that they often use charcoal to cook. And for them as adults, it's a practice where a mother can pick a hot piece of charcoal from one stove to another to help light another stove. And then when a child sees that, at a certain time, they're also going to try and mimic and try to pick a piece of charcoal from the stove, and they eventually get burned. So the type of energy then contributes to really children getting burnt. Lighting houses using candles is actually also a major problem, and sometimes it results in burning the entire house. Here we had a mother who said that they were using a candle to light their house, and when they stepped away to go and pick something from the shop, by the time they came back, the candle was already burning the child, and eventually the mother too got burnt in trying to rescue the child. So these type of energy used for cooking and lighting is a major risk for burns within our home environments. Location of the cooking place. In one of the surveys that we did, we found that there were more burns occurring in households that had no separate kitchen as compared to those that had. And in the picture, you see, a household where the cooking place is within the indoors and it's open. The child is very close to it, which certainly is going to drive the risk of getting burnt to be very, very high. A reach of hot stoves and hot surfaces also showed a strong association with the number of burns that happen within the homes. Again, in this photo, you see that the child is easily accessing a stove that is has a hot pan of porridge, and the risk there is fairly very high at any point. Open fireplaces, and we have talked about cooking in the open. And again, you see here that the numbers were still, high, burns happening for those that had open fireplaces in blue. And here you see a child, from one of the photos taken of the community during our photo voice work. The child was already accessing, a hot pan, which is also an open fireplace, and anything, can happen in a minute. The other risk that we see is matches within reach of children. And again, the numbers, fair enough, not as very significant, but yeah, you see that they're really, really high for where they had access to matches. And here in the photo, you see that this child easily has access to a piece of wood that is burning and can easily use it to, set a fireplace, a fire on the surrounding environment, which is actually full of flammable materials, but also even burn themselves as they try to navigate with it. The other risk that we was vivid from some of our surveys is light fluids within reach of children. And here, again, the numbers are not very significant, but high. A child in the photo already, setting up a fire, and you can see the smoke there, which could eventually burn him or even his colleagues. The other risk was around cooking fluids like paraffin or kerosene being within reach. In the pot here, a mother says that they use those paraffin lamps to to light the house, and often these lamps could get into access with say the house, the curtains or the mosquito net, and eventually burn the house and the child as well. So cooking or lighting fluids being within reach of children is also another major risk that we see. Spillage of hot liquids from the focus group. Still, this came out vividly that hot water from saucepans, coupled sometimes with forgetfulness, can easily result in children being burnt. And in the quote here, mother says that sometimes the child can crawl towards, a porridge that you've just finished cooking and put it down. And before you know, if you've, blink for a second and maybe you step away to pick a cup, you might come back and they're already burnt by the porridge. So that was also another risk that we see. I think at this point, let me invite Kenneth to share his experiences from the household inspections that he does from time to time. Kenneth is a health inspector at the Jinja City Council in the health department in Uganda, and we've been working in Jinja for quite some time. And we're happy for Kenneth to share some of his experiences briefly. So over to you, Kenneth.
Thank you very much, Ross, for that elaborate presentation. I think some of the things you have talked about is what was running in my mind. My name is Kenneth Nandala, and I'm a public health specialist. I'm currently working as a senior health inspector for Jinja City.
Kenneth, I can't hear you. Are you there?
May have lost
we
him.
have
I think we may have sadly. Oh, there he is.
hello, can you still
There
hear
you
me?
are. Yep, we can hear you again, Kenneth. Welcome back.
So about that, my network went off. Yeah, I was still introducing myself. I work at Ginger City Council as a senior health inspector, and I have experience in community and institutional inspections. We have a schedule where we go out and house to house and inspect these homes. And myself being a burn survivor, this is a very important topic because it reminds me of that time when I got a burn. I was about 10 years old, and it was a very painful experience that has stuck on my mind ever since. I'm working on inspections in homes and in schools, but you know that children spend most of the time in schools, and it is a place where they are at risk of getting these burns. So personally, I can emphasize to say that burns are painful, they are long term. I still have the scars on my body. I got a burn which affected my right arm, my belly, and my left leg. Thank God it missed my face and all the other parts, but I still have a scar in those areas. And this did not only affect me, but it also affected my family. I missed so many days of school, but also my family was devastated by what I was going through as a child. So burns are a serious thing, and we need to be able to prevent them in everything that we can do. This has driven my passion to work on prevention of these burns among the children that I work with. Charles has talked about the common risks, but of course, at households is where it is most critical that these bans happen, where people are cooking at floor level on a local stove, which is a spaghetti, or even an open fire, which is on cooking stones. It puts the children at risk of getting burns. Also, being a small space, living space, children also play near the fire, and so many of these children have got burns because they are within reach of the fire. These homes that we inspect here in Jinja are also overcrowded and also presenting a high accident risk for the children. The other causes of burns that we have found out in the homes that we inspect is the use of candles and kerosene lamps. Puts the family at risk of getting burns. Even use of gas and also flammable housing materials, for example, temporary structures which are made of boards and wood, also put the kids at a risk of getting burns. Tea and hot fluids like food, porridge, also put the kids at a risk of getting burns. And maybe the one that the one that people have not looked at is while bathing children, the water temperature is also not regulated, meaning that the kids are bathed with very hot water, and this can create burns in homes. In our inspections in schools, we have a checklist that checks on functionality of fire extinguishers in these public places. And you find that most public places do not have these facilities. They don't have the functional fire extinguishers or even fire detection systems. We have had reports of many schools in Uganda having their dormitories burnt down, and some of the children have lost their lives in the process. So in our inspections, we look at access to these sleeping areas to make sure that they are not blocked and that the windows do not have burglar in them, so that in case of a fire, the children can actually escape from that room through the emergency exits. Also, we have looked at fire assembly points, which help people to account for others. When a fire starts in a building, people run to that particular point and check to see who is missing or who has been left behind. This we have assured that all public places have these assembly points so that people are accounted for. Another thing we have looked at is safety training for the learners. From kindergarten, they are trying to teach them, the teachers are teaching them on harmful substances, and some of them are matches, fire. So the children grow up knowing that fire is a harmful substance, a hazard, so they do not touch it, do not approach it, and it is going through school. Possibly lastly, what I can talk about in my field of work is to ensure that these public places and these homes and these premises that we visit have adequate first aid box and first aid supplies, so that in case of a fire, someone can quickly get help and save their lives. The key message here that I can share is that risks are everywhere in the community that we work, and in the homes that our children live, and also in the institutions that they go to study. Thank you for listening. Back to you, Charles.
Very much. Thank you very much, Kenneth. And I think in your sharing, you speak to some of the things that you look out for in regards to prevention of burns from occurring, not just in homes, but also in the schools. And following, your reflection and my area presentation, we see that, burns are actually predictable within these environments. And so they should also be preventable. And how can we do that? We can redesign home environments, try and keep fire away from where the children are. We can work with communities to identify and modify local hazards, but we can also address the structural conditions that create risk in these places in the very first place. And some of the work that we, I think, have started doing in Ginger is to try and create, safe home environments, borrowing from, community-based participatory and designs and human-centered design approaches, where we've worked with diverse stakeholders, community leaders, technocrats like Kenneth, community members, policy makers, researchers, to try and brainstorm, design, and pilot interventions that can reduce risks and hazards for burns within the home. In that photo was a review meeting that we had with community members and leaders, urban designers, local artisans, weavers, and researchers. So we're trying to, validate some of the modifications that had been developed in consultation with all the stakeholders. And I'm sure my colleague Rollins will talk about this. That's it from me, and over back to you, Prash.
That's great. Thank you so much. Thank you both, Charles and Kenneth. I think just sort of quickly before I hand over to Lawrence, what you have shown and the sort of Kenneth, you have also talked very hugely about is what the data makes very clear is that the risk isn't distributed randomly. It's in clusters, it's in homes without a separate kitchen, it's at stoves at floor levels, it's at schools, open fires with flammable substances. And that household or school environment is not necessarily a sort of a neutral backdrop to these injuries. It's a determining factor, it's entirely predictable, and we can definitely do something about it. And I think, Kenneth, from your description, what you sort of personally described as well, from your own personal story, those long-term effects of what sadly happened to you had those effects on both yourself and your family. And I think it's a reminder that behind every data point and everything that sort of Charles mentioned is a trajectory that lasts years, often decades. And we're so grateful that you have turned that experience into a passion to help prevent injuries amongst children now. So I'm going to hand over to Lawrence, because I think, Charles, you sort of have brought that story right the way through to knowing what the data is about and figuring out what those hazards are, but actually now trying to really understand how we can do something about that. And Lawrence, I'm really excited to hear again what you have been doing with the Design Without Borders team. Over to you.
Thank you very much, Prash. Can you confirm if you can see my screen?
I can indeed. Yep.
Okay, perfect. And that you can see the switching?
Yes, we can see it.
Okay,
yeah.
Perfect. Thank you very much. And thanks to TGI, WHO for making this sharing possible, and to the School of Public Health, Charles and the team, for the fact that we were ever involved in this project that had to do with, we called it the Child Safety Kit from the beginning, but eventually changed the name to Child Safe Homes for recognition of the focus that the project eventually had. So I'll just do a very quick introduction of Design Without Borders, just to sort of explain what we do and maybe a bit of how we do it. We are a product and service design company based in Kampala, Uganda. That's where we are based, but we work globally and have projects in Tanzania, Bangladesh, really in many places around the globe. What I'm showing right now is an example of the kind of work we are involved in. It's really distinguished by how physical the outcome of the project is. And here we can see some product design projects. So these are really physical outcomes from the project. I'll maybe just highlight a very quick example, the B Pro helmet that we can see over here. I don't know if you can see my cursor, but it's basically the helmet there that's contextualizing that product for a tropical environment. So you can see ventilation that's incorporated at the top of the helmet for that purpose. And then maybe on the service design side, so these are less tangible outcomes. So services are really about systems, infrastructure, people, and organizing those elements so as to deliver like a valuable experience or to bring about awareness or to encourage specific behavior. So this is really what services are about. The physicality of the output of the outcome is a bit less obvious. An example that I can highlight is the family planning assessment tool, where the focus was to design a tool that could assess and simultaneously raise awareness of family planning sort of approaches to rural communities in Uganda. So that's a distinction between the two areas of work that we're involved in. But how the how of what we do is mostly revolves around the human-centered design process, like has been mentioned already. And this basically means so the three things that I would use to define the human-centered design approach is research. So the research component is really, really important. Number two is the fact that you have to work closely with the end user. So there's a bit of a mindset shift there that has to happen amongst intervention designers and program developers, is that no longer can we have interventions thrust upon communities. We have to involve them very intimately in the process. The third component is that solutions are built iteratively. So you're not going to get it right the first time. You maybe won't get it right the second time. And so you have to build a project design, the idea that you're going to have to keep trying and testing until you arrive at a solution. Most people ask me about how many times do you try and test? We usually target about 3 to 5 cycles of testing. But also, what's really important about this is there a few methods, tools that can be applied so that any team can actually try and incorporate the HCD process in the work that they're doing. I'm only going to cover about 2, maybe 3 or 4, depending on the time. So the positive deviance inquiry. So many of these methods and tools might be applied in different stages of the process, and you can see the discover, define, develop, and deliver stages. Positive deviance is very interesting in the research and the definition phase, because what this method or tool looks at is who within the same community, so the community where everybody is facing the same problems, who within that community is actually having a positive outcome, and what are they doing that's different from everybody else. So the assumption is they're being subjected to the same conditions, and yet somehow they have a more positive outcome. So those are very important people to involve in the process. Context immersion is really for the design team to understand what your end users are going through. And so you sort of have to bring yourself and be part of the everyday. In this image, we have DWB designer Sheila over there, the RNLI, who were the sort of the client or partner on this project, and then you have a group of fishers that were docking aboard And our team felt it necessary to live these everyday experiences so that we can understand a bit more the context within which drowning occurs. In the case of that project, drowning was the challenge we were trying to solve. Context and journey mapping is one that most teams shy away from, but it can be done in very many ways. The main aim here is to document visually what the everyday experiences of the users are, so that within those maps you can identify where the challenge is. So you know what's happening before the challenge reveals itself and after the challenge reveals itself. So this is just a map that we made again for the drowning prevention scenario. And that's in Tanzania. And then once you're starting to develop the solutions, it's really important that you're constantly inviting the beneficiaries to vote and to make their decision and preferences known throughout the process. So here we had fishers voting voting against the features that we could have integrated into a life jacket that we wanted to make available to them. So maybe coming more specifically, so the previous slides have given a very general understanding of the process that we follow. And that's basically the same process that we applied in the child safety kit project. And it did start off, so initially the understanding, at least within the design brief, was that it was going to be a kit of parts or a collection of tools that would help us address the problems. Cuts, burns, falls had scored very high on sort of the causes of injury, at least amongst children under 5 years. But of course, burns, again, being the subject of this presentation, were really high up on that list. So the prevalence was really, really much greater than many of the others. So poison, falls, etc. And these are some images. I think Charles has also shared similar images from the photo voice that was shared by the School of Public Health. Below, we can see immediately we involved a selection of community members to help us understand the situation. So we did have the data from the School of Public Health, but it's also important that as intervention designers, we interacted with the community members. But then moving from there, the brief, of course, had also anticipated the likelihood that this problem was more about the home environment, so less about the kit and this kit that can solve all the problems, and more about actual modifications that can happen around the environment. Here we can start to appreciate a bit of what that environment looks like. If you look at this image, you have a child sleeping up here, you have another child sleeping at the bottom there. This kitchen environment where cooking apparatus is all over the place and not even on very stable footing. So any of these equipment could fall. Here where you have lots of things piled up against each other and the storage condition is not necessarily optimal. This particular image is interesting because at first sight you'd think it's only garbage. So the lower left image, but we were actually told that there were electricity lines that were running within the ground, and the community had decided to pile as much as possible on the ground to hide those electric lines. So in many cases, what you see isn't exactly what it seems. And then this last one, of course, which is what I try to explain in the next slide, is that you had these conditions happening across different housing typologies. So in our analysis, it was very clear, of course, that you had very temporary structures, structures in transition. So the ones in transitions are really the ones where the occupants are very intentional about maintaining the structure at a certain level, that it's to a certain level that is habitable, but still predominantly temporary. And then you had the permanent structures, which are your typical buildings built from brick or concrete blocks, or in this case, actually concrete panels. So these are really, really durable structures. But already from the discussion, you can start to see how spatial the problem was becoming. It was becoming less about just products and more about, the architecture. And we do have a fairly good representation of architects at the office, myself included, who then transitioned into product design. And so it was an easy transition to make. Below these images on the bottom, you can see us involving the community members to start to understand the spatial conditions. We do this a lot where we use tape on the floor to zone out spaces and then start to do some design. So the plan is to get into some Mentimeter, but I see I've already used 10 minutes. I'm going to move forward, and then maybe at the end we can see if we have time to get into the interactive part. Here, I just want to explain that coming out of the research, we had design criteria that we wanted to follow. So surveillance was very important. It was very important. Whatever we designed, you'd have the guardians able to see the children. Supporting a local economy. Jinja is a very tourist destination. And so in designing products, we hoped that we could benefit the local craft sector in what we were making. They had to live within a system that would allow them to thrive as products on their own. DIY culture was about making sure the products can be repaired by the users, and of course the use of available materials. We went through some creative co-design with the community. This was to help us understand sort of the areas where they saw the solutions coming from, and then use this as a reference or a base on which the design team started to build further ideas. So here you can see cages for cooking apparatus. We thought through some ideas around creating these common play areas for children that would be shaded and raised on platforms that were soft and easy to build. Of course, some of these sketches also showed where the risks would be, because in many cases, by creating an intervention, you're also creating another layer of risk. So that we had to be careful that that wasn't happening. For instance, in this case, where we had this depressed play area for children. Sleeping areas where there was a risk that children would be sort of squashed by a guardian if they were sharing a bed, but that's of course away from the bands. Looking specifically at the bands was this idea around the possibility of creating this boundary wall for cooking areas, while also maintaining the possibility that guardians would be able to see where the children are. So that's surveillance aspect. On this page, I'll just talk about this one idea that didn't make it, but it was sort of a favorite in the office, which was this idea that because homes in informal settlements are very organically organized, you could have these informal corridors that could be closed off and prepared as a play area for children. It didn't go through because the community members were wondering who would be responsible in the short term for cleaning that space, which caught us off guard. This is a collection of some of the interventions that resulted. I'm just keeping my eye on the time. But with that, we also circulated these sheets that allowed us to understand that allowed us to collect information around how much the community members thought these interventions would cost, what challenges they saw, did they think that they could repair them, and all of that. And also, of course, the suggested pricing. So it's, how much do you think this costs, but how much would you be willing to pay to acquire this item? And then getting into the construction. So this is again the iterative building and testing. It was right in the middle of the COVID pandemic when most of this happened. And so we typically build these prototypes in the office before we take them out to the communities, just so that we can showcase exactly what the ideas should look like. But that was even more important in the COVID pandemic because there was not so much movement that could happen. And so this is us constructing a lot of these back at the office, the cooking implements that help us hide the source of heat, the mats that could help work as play areas, and then went back into the community and did this exercise where we got 9 households with the assistance of the School of Public Health, involved these 9 households that selected which of the products they wanted to test. We involved them in the construction of the prototypes. So you can see that happening here. So involved in the construction, involved local artisans at this point, also in the construction of those prototypes, and then had the community members prepared to use them. So this is a workshop where the community members were actually selecting, giving their comments based on the construction experience, the local construction experience. You can see guardians here. You can see these 2 gentlemen who are actually artisans that helped to construct them. And there was a very interesting conversation around the price, how they could be improved, what could the households afford, which was very interesting to learn from. And then here you can see some of those final prototypes in situ within the households. You can see the cooking implements. They are trying to hide the fire, trying to reduce contact with extremely hot surfaces, the cages, and the outdoor cooking ring, which was sort of hailed as a possible version of an outdoor cooking kitchen for the communities. I'll leave it at that. I see I have only about 3 minutes left. I don't know if that's enough for us to go through the Mentimeter. It would have made more sense to go through this before I showed you the rest of the process, but we'll try and do it anyway. Please, if you can, just scan the QR code on the screen. I'll also do it on my end so that I can see exactly what you're seeing. It will lead you to a link where we'll probably just look at one question and see what people think. I'll just change what I'm sharing as well. Okay, so if everything is working right, you should be seeing this. And basically in this image, I'm very curious to know. So the question that follows from this image is, in this image, what injury would you prioritize to address? Sorry, we'll just go back. And I don't know if we can start to see. So the idea is that, we get answers in real time. Let's just use maybe half a minute to look at this image critically. And there's just a very quick point that I wanted to make here. Which injury would you attempt to address first? And you can tell whether it's burns, falls, or cuts. Okay, so I hope we've had a good look at the image. We shall go to the next slide and try and see. Okay, so cuts. Okay, so cuts is scoring. Okay, that's changing. All right, we can see 9 responses out of 9 out of, okay. Okay, so I see that, okay, still changing. Okay, okay, we just have a minute left. Okay, so it's alternating between cuts and falls, which is very interesting. That's very observant. Hopefully you're looking at that image again. You can tell here that the cooking apparatus is there, but it's actually built into one of these earth cooking stoves. So it's definitely, it's right that, burns is not so much of a risk here because it's sort of dealt with. But what I wanted to explain in this image is how conflicted you could get as an intervention designer, as a designer, in what should be addressed first. And you can see us going between cuts and falls consistently, because you have these rocks here. Most of the households had these rocks present, because I think it helps with the drainage and, remove the flooding issue when it rains. But then you have all of these varying levels where the child could easily climb and fall, and you have all sorts of injuries happening. So when you get onto some of these sites, you're so conflicted about what you should solve first for the household that you're working with. It did help that we're addressing multiple injuries. So we attempted to create prototypes that could cover different areas. But this is a very typical experience while getting involved in projects like this. So I just wanted to make that point. And yeah, I think I'm more or less out of time, so I'll just stop at that. Thank you very much.
Thank you, Lawrence. Thanks so much. That's it's really fascinating. I mean, I've worked with you for a number of years, and I'm always learning new things every time I talk to you. And there's quite a lot that we would like to unpack from that, and I'm sure we'll bring some of that up into the panel discussion. But really, for me, it's looking at the sort of the design criteria, because I think that there are more that whole process that you talked about is much more demanding than it sort of looks. You made it look very simple, but locally sourced materials, community pricing, DIY repairability. Always having a child within guardian sight, that each of those is a constraint that I think most external design processes would probably root around, but you and your team really treated them as the brief. And what you ended up with, I think, is a result is something that was fundamentally really very different from what you'd get if you'd started working off in a lab or on a specification document, or looking at sort of solutions from other countries or things. And your phrase of what you see isn't the whole story, and clearly from that picture there, in terms of what you just showed on the Mentimeter, is really crucial, and it really pays heed to this type of important work in the sort of the prevention aspect. The cooking cage, the fixed station. These aren't global solutions adapted for Uganda. It's very much a specific ginger solution built from what ginger households told your team and worked with you to create. I suspect, the harder question, and I think you'll be the first to kind of raise this as well, is what happens next? We've got 10 households and we've got a proof of concept, and we want to build that more into a sort of a prevention program. And getting from that to that prevention program does require a lot of thinking, and it's very much a sort of a systems level question. And I think that really leads on to Zaitoon. I'm going to welcome you into the arena, because your work becomes very directly relevant. ChildSafe has spent years trying to answer that, not necessarily at the product level, but you do include that, but also at the level of how health systems, data, advocacy can all connect to actually sort of change what happens to children in the homes and those who are most at risk. So Zaitoon, I will share my screen for you and
thank you.
Welcome you to the screen. And there we go.
Thank you for this opportunity to, and thanks to TGI and WHO. But just, getting into the webinar thus far, I think, looking at ending childhood burns in Africa and, call to action, just judging from the presentations, I think it's fair to say that it would appear that we are on our way there with the brilliant work that's out there. Next slide.
Yeah, just whilst I'm doing that, Zaitoon, please do share your video as well, because we'd love to see you. If you want to turn your camera on, that would be great. But here's your next slide.
You want to turn?
Turn your camera on so that we can see you.
Okay, I'm going to do it for a short little while because I'm on wobbly.
Oh yeah.
In the rural region here, and okay. What have you done? Let me just focus. Here we have a picture of where ChildSafe South Africa is situated. If you can see the little green rectangular shape, that's exactly where we are on the premises of the Red Cross War Memorial Children's Hospital. And as Prasanthi mentioned earlier, Safety Conference 2026, there you can see Cape Town, the mountains are waiting to welcome you. Next slide. A little bit more about ChildSafe. Our vision is to create a safer world for children where every child can grow. Our mission is to reduce and prevent injuries of children through research, empowering education, and impactful recommendations to legislation through advocacy. And our programmatic interventions listed below are informed by our pillars of research, education, and advocacy. And what is important for us here, what we are focusing on the referrals from the Red Cross Hospital to ChildSafe, and that focuses on home and child safety counseling on those parents who have been through the system and in need of the prevention education so that we don't have repeats of these incidences. December last year, we also started conducting talks within the various areas within the hospital waiting areas, and we are focusing on the top 5 preventable injuries, and burns is definitely part of that. And just for the period of December to March, we have reached more than 2,000 parents, caregivers within the waiting areas. Our focus on the advocacy, the reduction of speeds in school zone is still one of our priorities. And then more so the injury prevention and harm to children discussions and conversations to be included, shaking the tree when it comes to policy discussions, that we can't look at measures of child well-being without taking the trauma to the child and burn injuries and these incidences into account as well. We also do lectures to medical students, healthcare professionals, and they, I think we found the niche there in terms of bringing the upstream determinants also into the conversation so that we can actually, bring it to the fore that each and every one of us can become that advocate for child injury prevention. It's how we frame our day-to-day works. We also do the early childhood development training. I'm currently out here in rural Free State where we're having a session over the 2 days. This is where we are focusing within our more rural communities with the early childhood development practitioners, looking at the developmental stages of the child 0 to 6. We are bringing in the injuries that is presenting. We've got various presentations, and burns is one of it, as well as the first aid training. We also maintain the Red Cap trauma database from the trauma incidences from the Red Cross Hospital. And that information is also used by researchers for ongoing research. And it also, informs our interventions. And community outreach and expansion of our various programs are ongoing. Next slide. This particular slide is just framing for me what it is, what ChildSafe has been doing, and where we still need to have our focus. In terms of the childhood burns, it's often described as tragic accidents, but really, if we think about it, it's amongst the most predictable and preventable injuries affecting our children, especially the young children under the age of 6. We are also talking about our referral pathways and how every child burn seen by the health system can either become a repeated tragedy or a point of prevention. We are aware that thousands of our children under the age of 5 are injured each year within their homes by hot liquids, open flames, unsafe cooking environments, and these injuries cluster in settings of poverty, overcrowding, and hazardous energy use. I also really liked the presentation by Charles, because as he was presenting it, those are our lived realities. You are out there in a totally different region, Uganda, but this is also a reality for us here within the South Africa. And I think the key thing for me here, what is often missed, is that nearly all of the children that come through the healthcare system, these opportunities, we don't always see it as how powerful it is, and it's underused. And that is why we started the hospital talks within the waiting room areas as well. We're sharing more of ChildSafe's work and how referral pathways can function not only as routes to clinical care, but also as prevention platforms, linking households, health services, data systems, and policy action. And I think very importantly, that every child burn should activate care, prevention, and learning. Next. Webinar 1 in the series has given us a lot of the data, but I think the important part one here is why childhood burns demand urgent public health action. It's because of the burns are overlooked as a cause of injury, disability, and death in low and middle income settings. And these injuries are predictable, preventable, and most of it rooted in social, environmental, and structural determinants. Reducing burns requires system-level prevention and not necessarily just the isolated clinical responses. And the next slide, the next 3 slides, it's from the Department of Health, Western Cape Government's Health and Wellness Directorate. And it is from the HECTIS, the electronic surveillance system. And I thought it would be nice just to give a snapshot and putting the spotlight on the burn injuries particularly. And this was done for the period of January 23 to the 15th of March 2026. So the number of incidences that was recorded was more than 17,400 in the age birth 2 years, and the percentage stands at a staggering 33.6%. The next slide. In terms of the 2 to 5 year olds, more than 38,200 incidences reported, and the burns is on 13.5%. And the next slide, the age group 6 to 10, over 41,000 incidences reported in the 6 to 10-year-old grouping, and the burns injuries stands on 6.9%. Next. The slide that you're seeing now, it's extracted from the Trauma Surveillance Red Cap database, which ChildSafe maintains of the trauma injuries from the hospital. There you can see last year we've had a total of 504 burn injuries, of which fluids burns is more than 75% and flame burns more than 7% of that. Interesting also to note is you can see the monthly numbers coming through with some of the spikes during certain times. And if we look at the burn injuries by age, it definitely speaks to when we make the statement that our children under the age of 6, that's most at risk. Here, the stats also indicates to us that in the 0 to 1 year age group, we had more than 32%. In the 2 to 4 year age group, it was more than 39%. And the 5+ was sitting on 28%. In terms of severity, the minor injuries recorded, the minor incidences according to the scaling used by the Red Cross Hospital, more than 45% were minor and more than 45% were moderate, and then we had severe cases sitting at 9%. What is interesting to note here, that this is just from the Red Cross War Memorial Children's Hospital, which is a tertiary institution. But this does not indicate what is happening and how the communities around the area and the drainage area use the local primary healthcare facilities when there are incidences. It does appear that most of them, because Red Cross Hospital is a children's hospital, they make their way directly bypassing some of the primary healthcare facilities. And I think that is why we are also sitting on 45% in minor incidences. Next slide, please. This is just a another slide capturing all the interventions, but more importantly also the podcast series that we also have, where we get the experts in the room to talk about particular incidences, and then put that also out on social media and share that. There we have Dr. Tume Mendes as the burns expert on our podcast series. Next slide, please. This is an overview of the ChildSafe's demonstration area, and Cindy, the middle one, is Cindy, our social auxiliary worker, doing her child injury prevention talks focusing on what she's busy with now, the safe candle demonstration, focusing on burn prevention in the waiting rooms. And then we also have our safe kettle strap invention that we are also promoting amongst our communities. Next slide. Back to Cape Town, where we operate in an environment of inequality and disparity, where those social, environmental, and structural determinants are common. Cape Town is also known by many of us as a city of two tales, the haves and the have-nots, but also the big disparities about what is happening in terms of urban sprawl, human settlements, and how urban sprawling affects our communities and the informal settlements that is just growing day by day. Next slide, please. I think this is one where we can just ponder on the determinants of health impacting injury prevention strategies and intervention, because I don't think, for me, that we can get away from focusing on preventing burns if we are not acutely aware about how the upstream determinants impacts what is happening. So within the upstream determinants are the conditions that shape the risk long before that child is burned or injured, where the families live, how the homes are built, what resources they have, what support systems exist. That's the outcomes of the wider social and structural realities. And if we can just go back also to Charles's presentation, you can actually also see how all of these things are lived realities. Within our South African setup, our socioeconomic inequalities, our education, the impacts of parental education on child well-being and injury prevention, or the lack thereof, our housing and infrastructure, our overcrowding, our poor sanitation, our unsafe water issues, lack of housing. Legislation and policy are also part of it. The child protection laws, the healthcare access to and policy gaps also still remains, those trees need to be shaken for ongoing advocacy. And then we also need, there are longer term solutions to these issues, and we need legislation. Urban planning needs to be changed. And then also we're looking at education and awareness, and very importantly, looking at the cultural norms, parenting beliefs, gender roles, and child discipline where this matters. But more importantly, if we just hone in on what we are still finding, what is happening on a daily basis within our communities when it comes to burn injuries, we are really working on trying to dispel the myths and bring the education to the fore that putting sunlight liquid, shoe polish, urinating on the wounds, margarine, toothpaste is not of any help. So you need to do have the wound and running under cold water. So these are part of the prevention and the education awareness that we bring to the fore, because that is still a major problem, the myths and the old wives' tales that some of our communities are still believing in. Downstream determinants are the immediate visible factors that directly cause the illness or injury. And to prevent burns at scale, we need to address the upstream. Next slide. I'm not going through all of these various deprivations that our communities are faced with, but I just want to highlight as an example the determinant where families live, what the lived reality is in Cape Town and across South Africa, the high density informal settlements, the limited formal planning, close proximity between structures, and the implication for burn risks. Fire spread rapidly between dwellings. There's limited safe spaces for children to play, and they are exposed to hazards in very close proximity. When we look at how homes are built, it's informal structures using flammable materials, woods, plastic, corrugated iron, and there's poor insulation. It's single rooms with multi-use spaces, and the implication for burn risk, we come back to the cooking and the heatings that occur within the same space where children eat, play, and sleep. Energy use is also a big issue. The mix of electricity, paraffin, candles, open flames, unsafe wiring, illegal connections. It's very, very common. And there are some households that still use the paraffin, the kerosene, and the implication for burn risks are there are high exposures to open flames, hot liquids, and unstable cooking and heating devices, and the reality of illegal connections within the communities that exposes children to great risk and harm. And the one last one I want to take from here is the caregiving context. The lived reality is our caregivers, parents, and grannies, they are often multitasking, busy with cooking, taking care of the child. They've got other income generation activities, and there are many times very limited childcare support. And those implications for burn risk is the reduced supervision at critical moments increases the risk of those contact burns. Next slide. Well, the important one here is household deprivation. It is a reality, and many children experience at least 4 simultaneous deprivations at the same time. So burn risks is not random. It clusters where deprivations overlap. The next slide. The next slide again shows our demonstration area, showcasing the lived realities of informal settlements. And what is interesting, picture 1, the jaw-dropping moment that we get from most of our caregivers coming over. Oh, wow, this is a scenario that they identify with. And in the second picture, we illustrate to them, if you just make small adjustments, you can create a safer environment to protect the child from burn risks and that. And the third picture is just to showcase when we have a situation and the history is taken as to why this incident has taken place, and the caregiver relates that the kettle was on the floor. And most of us would sort of like, what? But the lived reality for most of our folk, one room spaces double up as bedrooms, kitchen, bathrooms. And that is why we need to do more in terms of advocating for safer housing environments. Next slide. This slide just gives us an overview of the impacts and the reach of our interventions for the past year. I'm not going to go through all of it, but I think what is really key for us here is how we moved from just the referrals coming over to the child safe, and 35% for the last year were burn incidences, and why we've moved on to doing the talks in various areas of the hospital at least twice a week. And in the 4-month period, as I've mentioned earlier, we've reached more than 2,000 individuals who already have that relationship, if I can put it that way, with the health facility. Our early childhood development teacher training is also important, and we've reached over, that's just the children, but inclusive, it's more than 20,000 beneficiaries reached last year. The medical students and healthcare professionals is also an important one. That's the 4th-year medical students of UCT, University of Cape Town, and the 2nd-year medical students of Stellenbosch University, as well as the postgraduate diploma course that's done in general pediatrics and community development. Our expansion program for our injury prevention training is ongoing. So we've moved from currently with us being in the Free State today in 5 out of the 9 provinces. And we will continue strengthening our advocacy for child injury prevention. Next slide. The next slide is basically a summary of pulling all what we've said together. We can't just look at the one. Household deprivations is a reality. It gives us predictable burn risks. We can see how we use the primary prevention in early childhood and home settings in an effective point of intervention through primary interventions. Secondary interventions, the health system is a critical prevention platform, not only for a site for acute care. And the tertiary, we need to see how we merge and look at the data for policy action. Next slide. In conclusion, we need to look at prevention as a health system priority because burns are an equity issue. prevention is evidence-based and actionable, and I think systems collaborations enable scale. Aligning research, education, and advocacy across the health and ECD communities and policy platforms are important. What we've got, the slide that you're showing now, is what I want to highlight there is we also currently part of the Burns Prevention Management Framework through the Delphi study undertaken by the International Burns Association. Also currently engaged in collaboration with the hospital to provide trauma data to the National Department of Health to support the Ministerial Committee on Morbidity and Mortality in Children under 5, who advises the Minister. And this is the first time that this committee has ever started talking about including trauma and its role in childhood injury and death in these reports. We continue to advocate for trauma, injury, and prevention when it comes to indicators for child well-being. And as Prash mentioned, we've advocated for harm, injury prevention, and other to be included in the national strategy to accelerate health and action for children, which was signed off by government last year. In the next slide, I have spoken about, and now it's time for the video. There's no sound.
Aside from those, we know that most of our burns are being managed in the community or outpatients, and we conduct close to 4,000 appointments a year. So that's not individual patients, but that's number of consults that we conduct for burns patients. And it really is a significant burden. And we know that in the periphery and the primary healthcare clinics and the further hospitals that are in our province, they are seeing an even bigger number of burns because those are the burns that never make it through to us because they're being managed at home or at the clinic or by whoever's closest to them.
Mendes says the numbers of burn injuries in South Africa are higher than the world average. It affects poor households the most. A vital partner in creating awareness through outreach and education programs is the NGO Child Safe South Africa. Practical advice, such as demonstrated with this candle in a glass jar with sand, can be life-saving. The organization also educates people on what to do if a child has a burn injury.
The biggest thing that you can do in the event of a birth, take the exposed area and let it run under cold water for at least 15 to 20 minutes. If it's a bigger area and you have cling wrap, put the cling wrap around the area and get to a medical facility as soon as you possibly can. But we need to dispel those myths of the toothpaste and the butter and the eggs and those sort of things. It's still happening.
Accidents can happen in an instant, especially with open flames, a stovetop where a child can reach a handle of a pot, or with improper electrical connections. As much as 90% of burns are as a result of hot liquid, including bath water, oil, and kettles. Even a warm drink can cause immense harm.
Your skin's a bit thicker, you're a bit more resilient to injury. So if you were to spill a cup of coffee on you, you'd have a bit of a scald that would be a bit sore, but you'd probably be okay. Whereas in the same injury to a child will result in deeper thickness burns that may require admission to a burns unit or skin grafting or some sort of surgical intervention.
Treatment in the unit can range from at least 5 days to as long as a year. Not only hospitals like Red Cross offers treatment. While prevention is better, getting medical help urgently is vital, and clinics have trained staff to support victims. Referrals to hospitals are based on the nature of an injury. Mariska Botha, SABC News, Cape Town.
Next and last slide.
Despite
Thank
being
you.
preventable,
Thank you.
That's great. Thank you so much, Zaitun. That was really insightful and a really nice sort of segue. I've got a variety of questions and things, but I think the sort of main point that lots of points came out of your chat. Those numbers with nearly 6,000 burn cases under 2, with 5,000 in the 2 to 5 group. When you map those numbers onto the sort of the structural conditions that you described, those single room homes, the paraffin, the candles, those injuries stop looking just like random misfortune. And your discussion of the kind of the upstream determinants is really crucial to keep in the forefront of our minds. And I think what's been particularly effective about the child safe model is that it doesn't just wait for those housing conditions to improve before acting. So it works within the reality that families live in and makes every contact with the health system count. So it's home safety counselling, surveillance, and as a result, you're getting sort of pediatric trauma onto the agenda of the ministerial committee for the first time. It's a significant thing, and it's one that we should all really aspire to sort of see how we can get child health priorities set nationally. I'm going to ask my panelists to put on their cameras. We have a few questions that I'm trying to keep an eye out on for the Q&A session. And it would be brilliant to sort of try and move through those as we get on. If some of you, if I'm not getting to the questions, please do try and answer them as well. But I think maybe if I start with you, Zaitun, just because it's talking about sort of framing that problem. You've said that childhood burns are not really unintentional events in the way that we conventionally think of them. Can you explain what you mean by that and why that shift in thinking is so important? You're muted, Zaitun.
Sorry about that.
That's
We label and acknowledge that we label these incidences as accidents. But if we look at the data and the realities and the patterns, we can see ages, we know when these are happening, and it's hot liquids, it's open flames. And the predictability of this information is so powerful because it tells us where and when these prevention interventions can happen. So once we start looking at burns as being preventable, responsibility then moves from the caregivers alone to the systems where housing must come into play, the energy usages that is used, as well as the health services and policies that also needs to be addressed. So I think that is why we shouldn't just accept that these are accidents. We need to start, moving the needle with our thinking. Thank you.
Yeah, thank you. Charles, I don't know if you've got your camera on and if you can unmute yourself, but your data that was collected shows that obviously burn risk clusters in specific household conditions, but those conditions are also sort of markers of poverty. And I think, throughout the talks today, we've been talking a lot about sort of upstream determinants. And how would you go about sort of separating those sort of household hazards from poverty as a target for intervention? And does that distinction even matter in terms of, how we think about things, or how should we really try and look at those determinants that were talked about in the various sessions today?
Yeah, I think that distinction is pretty important. When you look at households, even within the slums, that can probably afford a little more space, so they are a little more organized. They have a kitchen. They can afford maybe to use with gas or electricity. They kind of do away with a bigger amount or big percentage of some of the risks. Same if you probably think about the rural areas, and that could probably be more organized in sort of like a household that has a kitchen and a separate house and a little more space to play with. You find that the risk profile will probably go slightly lower compared to a household in a slum setting that is sharing one unit for everything else that they need. So that's why I feel like, that profiling is very important.
Absolutely, thank you. I think there are a few questions coming in as well. One from Binta here. I think it's more of a comment. But yes, looking at this, I'm just going to read it out for you. Indeed, looking at this way, these are low-hanging fruits in changing and saving lives. When we assess priorities, we tend to think of burden as the highest number of deaths, and we look less at the opportunity that simple interventions can have, simple interventions. And I think that's really crucial to sort of keep in the back of our minds. I just wanted to look at sort of, in terms of the prevention methods and the examples that we've heard today and what it looks like in practice. Lawrence, human-centered design is a globally recognized process, not one necessarily that is familiar as much to the public health world. And I think it's becoming more and more like that. And you and us have been working together to try and promote that. But did you find it necessary to sort of contextualize the methods and the tools that you used in this project? And maybe also, whilst you have the sort of the mic, sort of somewhat linked here, drawing sort of feedback from multiple stakeholders. You've got communities, household agencies. How do you manage that? Is there ever a risk of too much feedback? And how do you balance that with the fact that, yes, they've identified some really key priorities that we need to take on board, but we have experts for a reason as well. And, how do you balance the kind of the knowledge that experts bring to the table with the community perspectives?
Yeah, absolutely. And maybe just to say, we've been applying the human-centered design process across several projects for at least for as long as I've been around, maybe 10 years, 11 years. And those tools and methods that we use have had to keep evolving. And mostly for some of the reasons that you've mentioned, which is that feedback comes in different forms. So you have people that might be able to sketch, but you have people that might not be able to. You have people that might be able to build more than they can sketch, or you have leaders in the room that might be more vocal than every other participant in the room. So we've had to change the way we fashion our core design sessions. In some cases, we've had to go out into the community and do a session in a live location where you can see the household, or in the case of the drowning prevention project, you can see the boats, and you can do like a role play session that shows how people act around either the proposed interventions or around the sources of the challenges. A lot of feedback definitely comes through, and so you have to be very careful about how, first of all, you document that feedback. So the documentation part really has to happen very, very rapidly. So you're either recording the session in audio format or video format, but then we usually also move in teams of between 3 and 5 with very specific roles and responsibilities spread across the team. So you have somebody that facilitates the session, you have somebody that's doing the note taking, you have somebody that's taking photos, recording audios, and then give yourself a chance later on to look at all of the feedback that you've gathered. But I'd really stress that it's these tools are constantly evolving, and even at the moment, we don't necessarily have the perfect tools. In the Child Safe project, we had to intentionally modify the way we were collecting feedback with our monitoring and evaluation tools to take them away from very text-heavy feedback to make it a bit more interactive. So you had a feature on the wall where there was a slot that could be filled in case the mother or the guardian had an accident with our intervention. And there was a slot for where a child had the accident with the intervention. And so we would come every few weeks to look at what had happened. And from these slots, you could understand immediately, without anyone having to write anything, who had an accident or whether there had not been any accidents. So it's things like that we are constantly trying to see how to tweak in order to improve the feedback. Yeah.
That's great. Thank you, Lawrence. And there's actually, I think there's a question that's been posed on the Q&A, which is directed at you about how the community reacted when the team introduced work on child injury and burn prevention. But I'm actually, if you don't mind, going to target that at Kenneth, given that you are the voice of the community that we were sort of working with within Ginger as well, and how, you know, some of the work that myself, Charles, Lawrence were doing and bring forward to the community. And when we met with you last year, what was the kind of the feeling on the ground, as it were, from yourselves and from the other community members as to you know, whether or not this was even a priority? Had the community sort of really accepted this as something that was needing to be addressed, and what was the feel on trying to bring in these sort of prevention strategies?
Thank you very much. I would like to say that in our field visits, the community's perspective has changed over time, because they now see the effects of burns and how they can even cause death to their children. And because there are very simple measures that can be put in place to resolve or to prevent the burns, they see it is possible. It's something they can do with the resources they have, without doing so much to prevent the burns. And over time, yes, they have kept it as a priority to keep children away from the fires, to make a raised fireplace, and also to separate cooking from living spaces. Most families are now building their fireplaces outside. If they have a single room, one single room, they would build a fireplace outside so that the cooking happens outside instead of inside. And also they have started taking up other alternatives, like use of solar lamps instead of candles, because it's a small squeezed room. They are now the communities now see that it's better to use a solar light, which will not burn the house down. But we continue to do our community assessments on safety, and also continue to provide education on risks in homes and also in schools, and also the best first aid to give when a child gets a burn. Because what the community knew is use of oil or toothpaste or the other things that the other presenter talked about, but we are telling them to do a 20 minutes cool of the burn and running water. So I would say the perspective has changed from the time I have visited these communities.
Yeah, it's really reassuring to hear, and sort of you know, nice to see. And I think, you know, talking as a researcher as well, from a research perspective, it's great to see that kind of forward drive and the sort of the impact that this kind of work is happening, and maybe changing the lens slightly as well. You know, we sort of, as researchers, want to be able to measure all of that, and sometimes it's organic and it happens on its own, and that's brilliant, and it's something that I think the research world needs to embrace a lot more of, that we don't necessarily have to kind of keep definite indicators of what's always happening on the ground, and, you know, just letting things sort of grow organically. And the Ginger Project is a real great example of that, because some of this work was done quite a few years ago now, but the momentum is still going. And I think, kind of speaking to you last year, you know, and seeing what the changes are happening, it's great to see that the community is still very much aware and doing things actively to try and prevent these injuries. I think Zaitoon, if you talk about the sort of the health system as a key prevention platform, and not just a sort of a place for treatment, what does that really look like in practice for you, in terms of, you know, the things that you guys have been doing at ChildSafe?
I think for me, it was always looking at, you know, yeah, they have the issues. The river flows. It's a big rock. The water's going to flow in any case. So it's sort of like taking, like, what do we do with the situation? If we look at the trauma and unit, and if we look at the waiting rooms at the hospital, those individuals all have that relationship now with the hospital because of an event that has occurred, be it burns, a road traffic crash, or whatever it may be. But how do we use that space to turn it into an educational space where we have low-hanging fruits of the community, the most vulnerable of the communities that use that facility? Let us start, maybe think differently and say, what can we do? How can we reach these individuals? And that is why we decided, and we engaged with the hospital and say, how about child safe coming into the space, engaging the different outpatient wards and the waiting areas, the pharmacy waiting areas, and we will do it. It's punchy. We focus on 5 top preventable injuries. Burns is obviously one of it, and we do a 25-minute hard-powered education on it and awareness with resources, and then engaging them. If they want to follow up with us, they are most welcome to follow up. And within this period of December to March, it was crazy to see that we've reached more than 2,000 caregivers, as opposed to the individual referrals that's being referred by the healthcare practitioners to us for the individual home and child safety counseling. So it just makes sense that, gee, if we can reach more individuals in that way, because the hospital has maybe over 140,000 of those visits throughout the year. Yeah, we just started, we are looking at the reach, and now we are amplifying to see how often do we do these talks so that we can reach a much, much bigger cohort of people. And that we are also asking them to share with families when they go back. But we are also, next week, we are having these talks recorded, video recorded. We've also worked with the hospital where we got funding to support screens in the various hospital areas. And that is now fully set up with media boxes attached to it. So these talks is now being video. We're putting it on video, and we are hoping that those are going to be screened throughout the hospital on a daily basis. So we catch the ones when we do the talks, but the messaging is there all the time. And within there, we are also looking at how do we use that facility, that resource that we have now, to start talking to these individuals. When I talked about the severity of the burns, that 45% of the burns that came in was it was moderate. Those are individuals that could have possibly made the stop at the closest primary healthcare facility. So putting those educational messages there as well, so that we can also reduce the burden on the tertiary hospital. But I think within these different setups, there are great opportunities, and we are looking in terms of forming collaborations now with the City of Cape Town's health care units, with the primary health care centers as well. How do we get these video messages also out to them as well? It's a starting point, and we're looking at the numbers and we see where it's going to lead us.
That's great. Thank you. We're running short on time, and I know that people have things to get to. But just kind of, I guess, maybe just a question to all of you panelists. Let me sort of start with maybe Charles first. Dennis last month told us that prevention ranks 11th in the burns research literature in terms of, the sort of the various aspects of care and treatment. And we've just seen programs where this clearly works. So what is stopping this from scaling? You've done a lot of work in Kampala and Ginger, and a lot of it is kind of quite context specific, but is it evidence? Is it resources? Is it political will? I'd love a quick response just from you all, just before we sort of tie up, and I think head on to sort of the last few slides.
Well, I think the evidence is there. It's more will, because you actually see from at least the community level, the communities are starting to do what they can do within their own, means. The households can do what they can within their own means. But then the will that probably can put more emphasis on that particular problem, I think that's where the challenge is. Also, given that for some of our health systems, they're more aligned to programs, and so you see that in programs where the emphasis has been talk TB, talk HIV, talk maternal and child health, and funding is there, and the policymakers quickly drift to making sure that those targets are met, and then all the other areas that are not really top priority are just struggling to cut edge. So I think for me it's more of the will, because like Kenneth said, the communities, when they realize where the problems are, they do what they can do within their own means. But then the next level, where now the policymakers are supposed to push, that's where the challenge is.
Yeah, thank you. I think I will have to call it there because we are running over time now. But I just did want to highlight next session that we have. Thank you to all our speakers today. It's been an excellent discussion, and I'm really appreciative of your time and efforts in coming together today and talking about the prevention aspects of burn injuries. I think some really crucial points have been made, and it's really interesting to hear the different kind of perspectives and the different ways in which we can approach prevention efforts across the African setting. So I'm looking forward to joining you guys next month for session 3, where we talk about the continuum of care. And you can see our colleagues there. We've got Dr. Shweta Gudwani, who will be moderating the session. You'll have just seen Dr. Toma Mendes as well on the video that Zaitun shared, and he'll be rejoining us along with colleagues from WHO and from Uganda, from the village health team there as well. So really excited to have that, and please do spread the word to colleagues that you think might be interested. I think the QR code at the moment is going to session 2, but it will change after this session to go towards session 3. So please do keep registered for that session. Just as a final request, if you wouldn't mind, please popping onto this link for us just to complete a short evaluation form to help us to kind of guide things, and also to give us maybe some comments about sort of how we can structure things as we work towards Safety 2026. But I just want to end with thanking Charles, Kenneth, Lawrence, Zaitun again, and to our WHO Afro team as well for hosting today, and to all of those who joined online. Thank you for your attendance and for participating and sending in questions. Thank you, everybody.
Thank you too.